Thank you, Rafael. Once again, thank you for the invitation. I'm always glad to be here at the Mount Sinai Division of Occupational Environmental Medicine Grand Rounds. Thank you for inviting me and for me to share some of this knowledge for the audience. I have nothing to disclose, and everything I say in the conference are my views as an expert and does not represent any institution in particular. Like Rafael said, I've been working my whole career in vulnerability and how workers in one way or another are vulnerable at work. And as Rafael mentioned, we've been doing a lot of work on informal workers. In fact, we just created a new technical committee in the IEA, the International Ergonomics Association on informal workers, also migrant workers, aging, child labor, workers with disability, and pregnant workers, among others. So, basically, you're a vulnerable worker if you have some type of intrinsic or extrinsic disadvantage to the general population. And for this reason, does not mean that you are not capable of being productive or capable of doing your job. It means that we have to be inclusive and adapt workplaces to the workers and their changes and their so-called so disadvantages that they may present. So today we're going to focus, of course, in pregnant workers. And first, we have to talk a little bit about how workplaces historically in the world have been creating disadvantages for women. It's historically workplaces have been designed with an androcentric aspect to it. In other words, things are designed for men. Usually workplaces are historically being designed for men. And you see the material, the equipment, workspaces are usually corresponding to male anthropometric. You see it on a lot of uniforms, for example, in some countries for firefighters. They all have front zippers, and women's firefighters just have to find their way to navigate through that issue. So in occupational health and safety standards according to male models. So this is the reality, but things are changing, and we're being more conscious, more inclusive, and that's why we're here to talk about many of these things today. And as you know, a lot of the industries are either feminized or masculinized. There's when I say feminized, are more predominant women, or some industries are predominantly male. For example, in the healthcare industry, which we're going to focus a little bit today, close to 90% of the population are females in some countries. In more developed countries, it's around 80%. But within the healthcare system, there are some specialties that are over 90% of females, and and there's also some male predominant industries such as constructions and others. So this is important. We need to understand that there's a difference. And with that being said, you have industries that are predominantly women, and at the same time, women have tougher, higher standards for them to perform their job, lower wages, less access to productivity resources, there's cultural aspects, fewer training possibilities, among other challenges. And women in healthcare, like I mentioned, almost 80% of the workforce around the world are women. And at the same time, we have a global shortage of healthcare workers. It's said that by 2030, we're going to be short 13 million health workers around the world. So what does this mean? This means that, a lot of the health workers are migrating from low-income countries to high-income countries. And then you have low-income countries with a huge global shortage of healthcare, which are predominantly women, and without the proper conditions and workplace standards for them to perform well while being a woman and becoming pregnant and other changes. Well, men, it's not the topic today, but it's also important that, that we know that there are also challenges with men in the workplace, lack of protections of men reproductive health. A lot of the work that the men do, are dirty, dangerous, discriminatory, and demeaning. Psychosocial risk factors due to social imposed masculinity, ergonomic risk derived to macho man culture. I can lift more than you, and you are not as strong as I am, and stuff like that. But that, we don't see that in the female predominant industry. But there are also, Dr. Nicolakatis, published a really interesting paper where there are some challenges that both sexes also have and overlap, like work demands, emotionally demanding work, psychosocial work exposure. Usually, what overlaps is the psychosocial risk factor and the cognitive interaction between the workplace and the worker. That's where usually the overlap is. Now, when we talk about women, women in reproductive ages, I mean, it's a natural process that women become pregnant. It's a miracle of life. This is something that we always should not only support but also be inclusive in the workplace. But the challenges come with it that are physiological. And I'm going to talk a little bit about the physiological changes, although this is not an OBGYN ground rounds, but it's important to understand, what are the changes, and with our occupational health specialist mindset, understand what are the things that are happening in the woman's body while we know what are the exposures at work and how can we best fit these work settings to these changes who progressively go through 42 weeks, 38 to 42 weeks. It's the basic principle of ergonomics. You adapt workplaces to workers, not vice versa. So, and this is no different. So, there are physiological changes, that have different risks, clinical, occupational for the mother and the baby, and there are some functional capabilities decrease, and there are some changes that happen through our body that we can talk a little bit about cardiovascular, for example. There's an increase of heart rate and oxygen consumption, reduced manual handling capability of loads, edema, varicose veins in lower limbs, lower tolerance to sustained posture, decreased venous return. Anthropometrically, well, we know that the body grows progressively and on a relatively fast pace. So it's not like we're doing a normal anthropometric measurement of the working population to adapt workplaces to workers. This is a changing anthropometric process that we need to take into account to protect the worker, to protect the fetus, and to maintain productivity and avoid human error and risks of accidents. And there are also hormonal changes, as we know. There's articular hyperlaxity, musculoskeletal alternations, which we're going to talk a little bit about, fluid retention, and also decrease of tolerance for repetitive motions in upper limbs. So these are all changes that happen normally. Either you work or either the woman is working or not working. So there's increased heart rate and oxygen consumption. And on basal metabolism, changes on oxygen consumption, heart rate, blood volumes. So you can just imagine, we have a decrease of capability of manual weight handling. And this is something that we need to understand. If you have a worker that works in a warehouse doing push and pulling, manual handling, or repetitive motion over the shoulder level, we need to understand that if the worker is pregnant, there are some changes that need to be made for this matter. Like I mentioned, less tolerance for sustained posture as well. If you have a worker that is on standing all day, prolonged standing or prolonged sitting, the alternating of the posture is more important than ever. I mean, these are recommendations that we give to everyone, male, female, pregnant, not pregnant, independent of your vulnerability. But with taking into account these changes on the female body while pregnancy, things become more relevant, and we need to keep an eye on them to protect them. Hypercoagulability, it's very important. If you, for example, are always sitting or always standing, these are risk factors that we have to understand and take into account. Dizziness, maybe a risk of syncope, for example, and that's something that we also need to include in our preventive programs. If there's a pathophysiological condition of preeclampsia, for example, there are a lot of issues that are affecting the body that we need to also understand and take into account. Body dimension changes, and they change quickly and they change weekly. By the time that the woman is 37 to 38 weeks of gestational period, the abdomen can grow as much as 14-15 centimeters in size. So these are things that also we need to understand when we adapt these workplaces. Body weight also changes, which will influence on the less capability of manual weight handling. Like I said, the abdominal prominence, 0.3 centimeters per week, and that also creates a higher pressure on the biomechanical pressure on your lower on your lumbar area, especially in L4, L5, S1. So if you're carrying weight and your abdominal prominence is larger, then the pressure will be more, and you have more risk of having a lumbar disc protrusion or a lower back pathology or pinching of the nerves and so forth. This is the same principle as we have male workers or non-pregnant female workers that we always tell them, when you lift your box, put it close to your body. Don't extend your arms. This is the same principle, but in this case, she cannot put it. She puts it close to her body, but the abdominal prominence avoids her abdominal prominence causes for her to have her the weight further from her body, and with extension of their upper extremities, does the pressure of the lower back. So the center of gravity also changes, and these are things that we have to take into account when manual handling weight. And there's an increase of risk of low back pain, which can be an occupational disease, of course. So hormonal changes, you have an increase of relaxin and progesterone hormones, joint laxity, periarticular constant muscle contraction, and you have exacerbated risk of musculoskeletal disorders. Retention of liquid, we can have medium nerve compression if you do any manual work with biomechanical pronosupination, along with force of your hand, using a tool or using any type of non-well set up ergonomically office. Then these are things that will affect your musculoskeletal system and will increase the risk of musculoskeletal issues. Of course, that's carpal tunnel syndrome, so it decreases the tolerance of upper extremity motions. And there are other changes, the increase of urine frequency. Of course, there's an increased risk of urine infection, and because of retention of liquids and the urine due to the higher frequency. But there's also the risk we're going to talk about later of you have to get up from your workstation more often to go to the bathroom to do your physiological needs. Decreased strength, visual changes, among others. So these are the physiological changes that affect workplaces and work processes. But there are also workplace occupational exposures per se that have nothing to do with the pregnancy that affect the pregnancy and the outcome of the relation between the worker and the workplace. So in the next few slides, I'm going to talk a lot about what we've always talked about as occupational health specialists. There are chemical, physical, biological, psychosocial, and ergonomic risk factors, which are, basically the main ones. There are others, but, these are the main risks that also affect pregnant workers. And having spoken about the earlier issues, now we can understand that we have intrinsic changes that increase risk factors, but you have the extrinsic ones, which are the ones in the workplace we're being exposed to, pregnant or not, that also exacerbate the issue. So, as we know, we have environmental factors, chemical, physical. I'm not going to go through these, we know these by heart. But at the same time, we also have to take into account that all these environmental exposures are not only affecting the woman and her health, but are also affecting the fetus, which is not only relevant, but we have basically two people to worry about instead of one. And that it's something that is not trivial, because you're not only putting in danger the life of the fetus, but also the life of the worker. So it's something that it's very important to understand, to acknowledge, and to include in our preventive programs within our workplaces. Psychosocial risk factors. We've also spoken about this extensively. We know that night shift works. It's an issue. The circadian cycles, and how does it affect mental health, and at the same, and it also affects the pregnant worker, which, by the way, it's already going through some issues of insomnia. Not all of them, but a lot of them are going some issues of insomnia, difficulty sleeping, and so forth. Excessive workload, more than 40 hours per week. If you're doing a preventive program, we should always think about this threshold of 40 hours. I think that the hours should be reducing progressively as the gestational period progresses, and we're going to see some publications about that. Emotional stress, discrimination, conflict between professionals, personal and family life. The typical, you're pregnant, you can't perform as well, or you're pregnant and some sort of retaliation. But there are some resources in place right now, legal and policy, international and national, which we're also going to talk about, that protect pregnant workers, and not only protect them, but also encourage employers to do accommodations accordingly to their situation. There's increasing, speaking about psychosocial risk factors, there's increasing literature and evidence in the literature that it's a vicious cycle. If you have musculoskeletal pain, then you become stressed, and this triggers all the stress hormones, and at the same time muscle rigidity and contraction, and vice versa. If you probably don't have an ergonomically well-designed workplace, but if you're going through some workplace psychosocial stressor that have nothing to do with the physical load, but have to do with retaliation, bullying, mobbing, whatever causes stress, that also affects the musculoskeletal system. So it's like a vicious cycle that there's growing literature on it that we have to understand and prevent. And when we talk about risk of work-related musculoskeletal diseases, we know that there are the typical triad of you have personal factors, you have physical, and you have psychosocial. And in the personal one, we talk about anthropometric. It is relevant to pregnancy. You have the genetics, smoking, prior history of work-related musculoskeletal diseases, but there are some personal conditions that if you're pregnant or not are part of the personal risk factors of the triad. But if you're pregnant, it does it does increase these the importance and the relevancy of them, such as the BMI, because you're obviously you're growing and you're heavier, you're larger. Your sex as being a woman, the depression issue, which is well documented during pregnancy and postpartum depression syndromes as well, which is another big black box that we don't talk about a lot, especially in the workplace. We assume that the worker just delivers and stays with their kid, with their child a couple of weeks or a few, and they're supposed to come back in tip-top shape just to perform as well or better than before. So this is not as simple as it seems. There are countries that in the world that give women up to a year of medical leave, and even the parents. For example, in Japan, they don't not only give the women a year for postpartum medical leave, but they also give the father another year. So I mean, maybe we're not ready for that extreme, but it just talks, it speaks to you in volumes that this is not a trivial issue, and that it's important to take into account in our legislation and the way we handle our preventive programs. So when we talk about occupational ergonomics is very broad. I'm not it's not an ergonomic lecture, but within ergonomics there's tons of subspecialties. When we talk about occupational ergonomics, we're talking about how does the product, the task, and the environment is influenced by the characteristics and capabilities and abilities of the workers, and how can we adapt these capabilities to increase efficiency, health, and wellness. I always include capabilities and abilities because sometimes we focus a lot on the disability of workers. If you're a disabled worker, or if you have some type of of specific disability, or if you're pregnant, for example, you can't do this and do that. But we usually, when we do occupational ergonomics, we try to focus on the capabilities of the person. In other words, what can the person do, so we can best take advantage of the worker and still become productive. So a little focus on ergonomics. As we know, healthcare workers are probably one of the largest industries in the world that employs the most people, and 80% of them are women. And a lot of them, I don't have the numbers. I looked at some of them, but probably half of them are in reproductive age. So if you're talking about women in healthcare, for example, nurses or nursing assistants who are manually handling patients, and they have the issues of handling loads, forced posture, repetitive motions, that it is not the same as a worker who is not pregnant. And considering the global shortage of healthcare workers, this has become a real issue, because a lot of countries, and here in the US as well, are forcing people to come back to work a lot faster, and made of all the things that I just mentioned in the first half of the presentation. So manual handling of burdens as a predictor of birth outcome. So now we're going to talk about the fetus a little bit. In 2018, Dr. Kewuri Afu, at the European Journal, published at the European Journal of Public Health from the Finnish Institute, that manual handling decreases placental blood flow, increases the risk of preterm birth, miscarriage, low birth weight, and premature ruptures of membranes. And I've seen this in the literature, and we've seen it in the literature again and again. And these are things that unfortunately are not spoken enough, and we need to, and that's why we're here today. And we usually hyper focus on the exposures and the risk factors who are bluntly in front of our eyes. And I can give you an analogy. During the pandemic, we rightly so hyper focus on health workers, but then you had all types of non-health workers, essential health workers, going out to work every day, and nobody was looking at them, and we know what the outcome was. So, I mean, I don't know if it's a good analogy, but the idea, the message here is that sometimes we see the pregnant worker, and we try to protect their shoulders and their knees and their lumbar area, which is important, but there's also a fetus growing in her that needs as much attention or more attention than the worker that it's themselves. Occupational risk factor for musculoskeletal back injuries. Well, we know, like I mentioned before, there's a good study in 2021. Dr. Rainbow, it was published at the International Journal of Nursing Studies. I can share all these references. How the manual patient handling, pushing, pulling of beds and trolleys, awkward postures during patient care affects the pregnant worker significantly. And nurses are among the professions with the highest rates of work-related back pain. So, and if on top of that, you have a 24-week pregnancy or a 20-week pregnancy, increasing the biomechanical pressure of your lower back, then obviously these are things that that are not only relevant, but it should be a part of our preventive program in all our practices. Continuing with the occupational risk factor for pregnant workers, some studies have indicated increased risk of adverse events for pregnant physicians, for example. Rates of pregnancy complications are higher in general female population, and complications in early pregnancy can be attributed to the exposed to chemical gases, radiations, and other infectious diseases, as you can imagine. Working long hours with high levels of psychosocial stress through, it triggers the whole stress hormone system, and it mediates also the alternation of uterine blood flow among other issues. The study reported in a survey that general residents who were pregnant during the training, they perceive a stigma of pregnancy and motherhood by peers, psychosocial risk factors, and biological risks have always been attributed to health sector pregnant workers. There are more risks that can affect them. Recently, this year, March of 2023, I encourage you to also read this letter to the editor, a publication. Dr. Harbour, I'm just quoting a part of the publication. It says, when one of the residents was talking in the paper, and says, one of us, SK name, became pregnant as an intern and didn't request nor was offered any adjustment to her schedule. When she developed preeclampsia and required 1 month of bed rest, concern about whether she was burdening her fellow trainees added to the stress of worrying about her fetus and her own health. When she returned to work after delivering an infant with low birth weight by emergency cesarean section, long shift compounded the exhaustion associated with carrying a newborn. So I really don't need to explain this quote. It just speaks volumes, and it's something that we need to digest and be inclusive and respectful to pregnant workers as any other worker that is going through a vulnerability, if it's permanent or transitional. All right. So risk to fetus, structural and functional abnormalities, heart, extremities, urinary systems is being well documented as well. Central nervous system, genitals, low birth weight, growth disorders, preterm birth, delayed intrauterine growth, and the risk of spontaneous abortion, fetus born dead, early, late, neonatal death, and so forth. There was a good literature review that was published in the University Medical Journal, and I encourage you to read it. They looked at a lot of the publications out there, and they created kind of like a table of a well-referenced table with all the impact of ergonomic stresses during pregnancy and recommended practices. I think that this is something that like we should all do within our health systems and within our practices, where we should understand what are the ergonomic stressors that pregnant workers are being exposed to, what are the risks in the pregnancy, and what are the recommended practices for safety. Now, the recommended practices for safety are going to change. I mean, the recommended practices are up to us as practitioners to implement, depending on the product, the productive process of the company, or of the employer you're working for, or the workers you're trying to protect, whatever. So, because as you know, depending on your productive process, risk factors changes. So we know for example, work shifts, prolonged work hours, prolonged standing, prolonged bending, overexertion. They list them all, and these are the risks of pregnancy based on the evidence-based literature, and we should modify, the recommended practice depending on where we work. So, actually, this is a good practice to do on any workplace intervention. No, not only for pregnant workers, but if you have, for example, workers with disability who are blind, or you have aging workers, for example, who are their physical capabilities are decreasing, but so and so forth. So I think this is a good practice for today's talk on how to limit and decrease the risk factors. And they also took into account within their literature review, occupational fatigue, work-related falls, and so forth. So although the literature review could have been done a bit better, but it does give a lot of good insight and good information on how to approach this the right way. So, design. So what do we do? So how do we solve this problem, or how do we even approach it? So a basic principle of ergonomics is to have an inclusive design. We're all different. Some of us are short, some of us are tall, some of us are wide, some of us are pregnant, some of us are old, some of us are young, so and so forth. So if you understand how the workplace is set up, and you understand your population, which you're trying to protect, then you try to adapt these workplaces to the workers. And it's no different with pregnant workers. So like I spoke before, we usually focus on manual material handling, awkward postures, and repetitive motions. And there are some ergonomic evaluation methods out there which we use constantly. We have, the Snook and Serial tables for pushing and pulling, which assesses what is the appropriate push and pulling weight and distance that we should do to avoid musculoskeletal issues. We have postural ergonomic evaluation methods such as the OWASP, ruler, REBA, and there's many others. I'm just listing a few. We have repetitive motion evaluation methods such as OCRA, HAL, and really, I always mention this on my talks, but there's hundreds, if not thousands, of ergonomics methods out there. In the Ergonomic Association and the International Ergonomics Association webpage, Technical Committee of Musculoskeletal Disorders, you can go in there and download all the recommended and validated ergonomic methods that we tell the world. These are the most reliable and validated. These are just a few I'm mentioning, but none of them, or very little of them, take into account vulnerable workers, disabled workers, pregnant workers, aging workers, and so forth. Right now, we're having a little shift into including exposures such as psychosocial, stress, environmental. We're starting to take into account, working on high heats or low temperatures, working on vibration, working and so forth. So things are moving and improving. But we're right now really in diapers, like I say. There's a lot of work to be done, and we're doing some of this work at the International Ergonomics Association and on the Musculoskeletal Health Council. But really, the most important thing is, the best ergonomist is not the ergonomist that knows more methods. If you want to do a good practice in ergonomics, you need to understand what is the exposure, what are the correct methods to use, if you're going to use one or more methods, or if you even need a method to assess our ergonomic risk factors. Sometimes just with observation, you can come into conclusions and give impactful recommendations. But reality is that all these methods are designed for you to have a tool as an expert to come into conclusions and give recommendations tailored to what's happening at the workplace that you're studying. So you can adjust the conversion factors respectively to lower the risk factor threshold. If we adjust the conversion factors of these methods, for example, for pregnant workers, where we lower the threshold, so we're protecting the worker, because we need less exposure for the methods to give us a red light. So these are things that we need to keep working on, and it's important to understand and to have the right expertise and competency to really protect workers when they need it. There are some methods out there that are specific for pregnancy. I'm not endorsing any of these, but it's important to know that they exist. And they are, they do take, specifically into the account the pregnant worker. It works well, but I usually use a few of them. I don't rely on one, and of course on your expertise and your observation, and most importantly, really, it's the participation of the worker. I mean, the worker gives you 50% of the diagnosis, and having a participatory approach in ergonomics, it's not only important, but I would say that it's indispensable and it's critical for a good intervention. So this ergonomic methods suggests that, for example, if you're 6 months or less in pregnancy, and you do repetitive motions more than 4 times every 8 hours, you should manual handle no more than 5 kilograms. If you do intermittent repetitive motions less than 4 times an hour, you can manual handle up to 10 kilograms. But then again, these are suggested, validated methods that give you a risk factor for a pregnant worker, but every situation is different. This is not a one-size-fits-all situation or assessment tool. We don't know the age of the worker. We don't know the temperature they're working on. We don't know if there's occupational stress, psychosocial risk factors. We don't know if the person has complications, if he has preeclampsia, and so forth. But it is a tool that we can use, but it's just a tool to complement your overall assessment as an expert in the workplace. Same way with how much should you or should you not carry the weight? Should it be close to your body? Should it be over the shoulder level, under the shoulder level? And these are the same principle that we use in the NIOSH manual handling equation for non-pregnant workers. It's just a modification of the NIOSH NIOSH ergonomic assessment tool. Dr. McDonald in 2014 published a good article where they did a flow chart on how much weight the person should handle, and they started at performing does your work perform lifting tasks more than once every 5 minutes? And if not, then there's recommendations. If yes, then the flow chart moves to the right. And do you lift more than 3 times per minute? If no, then the flow chart goes down, and then it asks you how many hours per day do you spend lifting at work? Less than 1 hour or more than 1 hour per day, and then it gives you recommendations. So you can see that as the flow chart moves to the right, and there's more exposure to weight and repetitiveness, then the amount of weight, when there's more exposures of timing and of repetitive motions in timing, then the weight modifies as we move, as the exposure increases. And it comes to a point where the suggested method cannot give any recommendation if the patient manual handles more than 3 times per minute. So like, again, these are just tools that we use, and there's hundreds of them. Some of them take into account pregnant workers, some of them don't, and this is up to the expertise of the person doing the assessment and the intervention to consider these tools. Awkward posture, risk of preterm delivery, and we spoke about also the lower extremity exposures, and as well as fatigue, dizziness, and potential fainting. So if you're working more than 1 hour to 4 hours a day, between 1 hour and 4 hours a day, then you have prolonged standing. As the same way as prolonged sitting, if you're sitting more than 1 hour continuous, there's the same exposures as people who are not pregnant, but then we have to take into account all the issues that we spoke earlier in the presentation. The same way, if the chair is too low, the chair is too high. If the chair is too low, at the same time, we have an hyperflexion of the hip and hyperflexion of the knees, and there's a biomechanical load, and then you have of course, a growth in the size of your abdomen, and obviously it becomes an issue. Lateral inclination and rotation of the trunks, we should avoid more than 20 degrees, more than 1 minute continuous, or maybe 2 times every 2 minutes. These are just suggestions that are in the literature, and a lot of them have not only make sense, but also when you see it in the practice, the workers tells you, every time I flex my trunk more than 60 degrees, this happens. Every time I flex or extend my trunk more than 20 times, and this happens. So this is not only in the literature, but we also see it in the practice. And obviously, there's more research needs to be done on all these issues to create more evidence, and not rely so much on the expertise of the practitioners, which is the bottom of the evidence of the pyramid, but work ourselves up toward more evidence-based science. So there's a huge opportunity for research here. The gap is immense, and the need of the workers are, of course, very, 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 very big. Workplace accommodations, usually the first thing we think is like, don't move, don't do anything, blah, you're pregnant. Really, the literature have said that, has evidence that, you should not decrease your physical activity. Rather adapt the conditions to the changes of the pregnancy. It does seem challenging, but there are ways to do it. And with the participation of the workers, and of course, with the experts, we can do this not only correctly, but also in beneficial to the fetus and the worker. Avoid manipulation with risk to blow of the abdomen, avoid wearing heavy protective equipment. These things might seem obvious, but you'll be surprised when you go out to workplaces, the things you see and the things that are not taken into account. Organization designs and recommendations, perform tasks under the abdomen, do not handle loads, under 25 centimeters, over 120 centimeters. You have to change the process, frequently alternate the posture, encourage walking short distances on safe ground, and so forth. Adapting the workplaces, we have to, on offices, for example, we have to understand that we have a gravid abdomen that increases in size. So there are some resources out there in that we can purchase to adapt workplaces to workers. Spaces for lower limbs, postures on sitting on high chairs. This is very important. I think one of the largest risks of accidents, evidence in the literature, is the risk of falling of pregnant workers when they have to get up more than 10 times an hour, or very frequently, forget about the times, just very frequently. So they have to sit and get up, sit and get up. So for that, we do adaptations and we create semi-sitting or semi-standing stations. So, she can sit or stand as many times as she wants, but, it gives her the opportunity to alternate the posture without having a larger biomechanical load. And this is just, another way. These are very similar to the semi-sitting stations in the pharmaceutical industry or laboratories, where people have to get up so frequently, that you have semi-sitting stations. Of course, using devices for patient manual handling, live or decedent, it's important. And when we do best practices, it will be the same way we do, but based on the same principles as any other design in the workplace. We have to do prevention through design, and of course here we obviously PPEs can be useful for pregnant workers when you're exposed to radiation and ionizing radiation, for example, and so forth. But really the biggest problem we have is musculoskeletal issues and cardiovascular issues, and there's really no real PPE when it comes to that, unless we and there's a food for thought, maybe a research or entrepreneurial aspect of inventing an exoskeleton type of device to help pregnant workers to perform better and protect their health. Workplace accommodations, same as any of them that we always do, but we also have to understand that there are also regulations and policies out there, international, who protect workers. There's a maternity protection, and here in the U.S., it's been a long journey. In 1964, the Civil Rights Act prohibited discrimination on basis of race, color, but there was a color, religion, sex, or national origins, and so forth. And it was a tremendous step forward on protecting workers in civil rights. But it really did not address, or wrongly address, some civil rights, such as pregnancy at work. Then in 1978, the Pregnancy and Discrimination Act passed by Congress, and which partially closed that gap, but really didn't give clear instructions for us up to how, although we knew the science behind it, it didn't really give instructions or the encouragement for employers to do these changes. The 1990 American Disability Act also provided accommodations to workers with disability and included pregnant workers, because some of them, although pregnancy is not a disease nor a disability, the process of the pregnancy process does decrease the worker's ability to do some tasks. So, it did include them in some way, but it was not really clear. So despite all these laws, many of these pregnant workers fell through the gaps and have been experiencing adverse employment action due to their pregnancy, childbirth, medical related conditions, and so forth. So right now, we in the United States, we have fortunately have moved forward a long way We have most of the states protecting workers against discriminations. We have most of the states protecting workers for pregnancy accommodations. We still have to do a little homework on workplace breastfeeding rights, and that it's that's something that we should look into. But there are some states that do have breastfeeding right, which is very, very important. We have to remember that that the psychosocial risk factor and occupational stress that this causes when you don't have a place to breastfeed does impact the productivity and your health at work. So it is something that we have to look into as we see it on a total worker health approach, and it's just not the actual micro ergonomic exposure to the workplace. There are some state guidances on pregnancy. In New York State, we have the Division of Human Rights with some guidance. California has the Pregnancy and My Job Roadmap, which is, I think pretty comprehensive. But I think right now we live in a golden moment where we all should know and understand and take advantage for research, policy, and implementation. In 2022, the U.S. passed the Pregnant Workers Affairs Act. It's a long overdue protect workers. And as recent as June 27, 2023, it was approved and it was put in place. So now we included current workers and applicants. In other words, you don't have to be a worker. An applicant that's pregnant is also protected. Clarity on workplace accommodations. Make sure to keep capable workers employed, which is, I think, one of the most important things. Workers are capable of working despite of their changes. We just need to adapt the workplaces to them. And contributing to total worker health and employers' productivity and the overall economy and society. If we have workers being productive despite of their pregnancy, this it just benefits everyone. And encourage everyone to also go and participate. And look at the public comments period, which just closed on October 23rd. The comments were very interesting, and there was a lot of good feedback for us. So there's a QR code where you can go into the website and look more in depth the Pregnant Worker Fairness Act. I think it's a model that we should not only follow but also take as an example in other countries. I see we have colleagues from other countries logging in that were recently here on our conference that we held here at New York Academy of Medicine last week. So I encourage you to see. It's a good initiative, and at the end, all we want to do is be inclusive and give dignifying workplaces for pregnant workers. And I want to close with acknowledging Dr. Danilene Lozada from the ICOH Scientific Committee of Women, Health, and Work, who was actually the pioneer of this project. She's also my wife. And we're here just, if anything is needed, we can ask any questions. There's my email. And I don't know if everyone remembers not too long ago that there were 9 nurses pregnant at a labor and delivery main hospital at the same time in 2019. So you can just imagine what the situation was there. All right, so thank you very much. That's what I had for now, and I'm open for Q&A.